two of our researchers in NIMR. To my left is Dr. Chika. Started with zoology and parasitology. Did a master's in cell biology and genetics. A PhD in cell biology and genetics. He's a deputy director of research. He has not only worked in that, I believe you've been with NIMR for the past 21 years or more, from instance. So he's my senior in NIMR.
Please scratch that part.
He has been microbiology, but also particularly in genomics, looking at different genes and how they have influenced some disease entities. He will telling us more about it. What's peculiar about the genetic makeup of Nigerians and why we had the experience that we have with COVID. The whole world felt like COVID was going to devastate our society. What is it that made us not be that susceptible? And to my right, Dr. Emma Ekelda Chukwu, another microbiologist who has been involved a lot with antimicrobial resistance studies, has done a number of things in the area of water analysis, checking for any abnormal microbial agent, essentially dealing with the purity of water. She has also been in NIMR long before me. So as you can see, NIMR is blessed with researchers who are trying to improve the health of the environment. One thing we are trying to focus on are essentially research in areas that are relevant to the man on the street. Nothing esoteric. What sort of water are we dealing with? Do we have any environmental health challenges? Look at the issue of diabetes. Are we having toxic fumes that could be affecting respiration? What sort of risk factors are we running that predisposes us to hypertension? Are there any peculiarities in our environment touching on renal diseases?
So I'm talking about human papillomavirus and what we have done in that regard. I have first a disclaimer. I'm happy Professor Ezechi said I'm not a medical doctor. I'm a PhD doctor. So most of what we do is like testing for it, find out the types available, and the information can be used by governments to help them do some things. So human papillomavirus is over 200 different viruses. So it's a lot, but only a few, about 15 of them, are actually called high risk because they can lead to cancer. They will cause the cells to change a little and ultimately it can lead to cancer. But the good thing to know is that in most people, the cancer is not concerned because the body can just clear them. Some of them consider like genital warts, maybe some warts on the skin and some other things. But 90% of people can clear them, especially young people, younger than 30, can easily clear it. But the issue is when it is persistent infection. When the infection persists, it now goes ahead to go and create some changes, which if not treated, can lead to cancer. It can be prevented in vaccines, and that will be kind of what we'll be heading towards at the end of this. Prophylactic vaccines can cure it and keep these cancers away from us, and then they can have screening. People going to check early so that we can prevent this thing. Now I'm trying to look at the landscape, what is going on globally, and then we're going to Nigeria. Over the world in 2020, there was about 604,000 cases of new cervical cancer, and then 342,000 deaths in 2020 alone. By the time they segregated it against men and women in 2019, you will see it stacked against women. 620 cases, 620,000 cases in women, and only 70 in men. So you see it's appropriate towards women, it affects women a lot more. And then it comes to like losing one woman in every 2 minutes to cervical cancer. So it's something we really need to treat. By the time we go further, you see that even in LMIC, the low and middle income countries, that's where it's a lot. And that is why we must attend to it. In Nigeria in 2020, there were 12,100 patients, along with 8,000 deaths in Nigeria in 2020 alone. And we and I know that our documentation may not be also accurate, but at least that's the one that they documented. And much more disturbing is that in Nigeria, we have more than 60 million women aged 15 and older who can be sexually active and who may be able to contact the virus, who may now be able to have cancer if they have all the other scenarios around it working. So there's something that the WHO has set in place. They call it 90-70-90. 90-70-90. It means that 90% of girls should be vaccinated by their age 15. 70% of women should be screened by a high performance test at the age of 35. And 90% of those who have identified as having cervical cancer should receive treatment. So in looking at a lot of this, in high income countries, most of them have introduced HPV vaccine that have taken down the disease and the infection. But in LMICs, only 41% versus 80% in high income countries. And all of this comes to the fact that it's a bit expensive. The vaccine, some of them cost $100. So it's a bit expensive. But the Nigerian National Strategy for Cancer Control and for the control of cervical cancer has come up with things that can help us. And they are going to do that by even tackling young girls, 9 to 14, and treating them and vaccinating them. So glad to tell you that I think many of you should know, in 2023, Nigeria has implemented this vaccine among routine immunization. Can we clap our country? We got it right. We are trying to bring it in. Some of the things around the procedures we're going to tell you, the jingles and everything that needed to go along with it. But at least they started. They are among the countries that have started. Now they intend to vaccinate girls 9 to 14 with single dose of the vaccine known to be highly efficacious. I'll talk a little more about that. But there was something our minister said when he was talking about this. He said the loss of about 8,000 women yearly from a disease that is preventable is unacceptable. And he said he's talking as a father who has 4 daughters. That's our minister, Mohammed Ali Patel. He said, I have 4 daughters, and I'm talking as a father that we need to be able to do this vaccination. So working with Gavi and some other partners, we are paying for those vaccines and bringing them out. But for us to appreciate the scope of the problem, West Africa has the highest prevalence of cervical cancer, 24%. In terms of the regions of the world, 24%, followed by Latin America and Caribbean, 16%, Eastern Europe, 14%, and Southeast Asia, 14%. So these are things we need to look at. Now, all the cases of cervical cancer, most of them are caused by those high risks. I was saying it's about more than 200, but it's the high risk, a small group of about 15 that actually cause these cancers. Remember the persistent infections, and after that infection, it takes about 10 to 15 years in people whose immune system are working to be able to cause cancer. But people have low immune system or weakened immune system, like people are HIV positive, they can go to cancer in 5 to 10 years. So a lot of factors are in there, meaning the type of HPV infecting the person, the immune status, and different other things. So how can we know who had this? There are different tests, but most of what have been used have been clinical tests, like the pap smears, like the colposcopy, and then visual inspection with acetic acid. But these are clinical things, and most of the time, the infection has gone for a while and is already producing a change that they detect. So now they are going to something that happens before that change physically. That's detecting the virus, human papillomavirus, HPV, first using DNA tests, using PCR to detect them early so that people can be tracked before a change occurs that can lead to cancer. So I'll talk about some of the things we've done about it. Working with some colleagues, we've done a survey across the 6 geographical zones of Nigeria. And that survey was over 4 years, January 2015 to December 2019, all through the 6 geographical zones. And we did that test, we are detecting the human papillomavirus that caused it. And that has been published, but the key thing is that 570 people were recruited. And we saw that the key ones, 16 and 18, they are the key human papillomavirus that cause almost 70-76% of the cancers. They were very little among the people. The bulk of the infection was what they call the other high risks that are different from the 16 and 18. Several other things that they know when you do these surveys, we ask different questions, ask you, oh, how is your maybe your sexual health, what is your maybe some practices you do. There were a few they are associated with infection. Some of them were people have genital warts, people that were HIV positive, and then abnormal vaginal discharge, and very importantly, people that have multiple sexual partners. Because one of the things with this, you have to be sexually active before you can catch it. Even though there are some other scenarios, but sexually active, and we can talk about different, I'll leave Professor Chika to help me with the different types of sex that will lead to it causing either the cervix or the anus and different types of cancer it can cause. But in that test, in that survey, we did not find it associated with contraceptive pills. It was not associated with cancer use, and then if you had previously terminated a pregnancy, it was not associated with it. Now, in the second one, I had a trip that the Institute sent me to China, and when we got back, working with those Chinese people, we were able to start a study. One of the things about it was in the bulk of the COVID-19 in 2020. So we had sent out some kits to people all over Nigeria trying to do the same 6 geopolitical zones, but only from the south did we get things back, because in the north they couldn't do anything in the thick of that COVID-19. So the things were, we first had to get ethical approval from NIMR. Then we had to go, because the study was in Lagos here, I was leading one in Lagos here, we had to go and get ethical approval from Lagos state government, and then the China CDC also gave approval for that study. So to make sure that everybody was looking at it and what we intended to do was fine. One of the first things was to check, particularly in Nigeria where, I don't know, we don't have much, I don't have the statistics, but we don't have many female doctors as much as male doctors as we would like. And in some areas, people can be far away. Some people can even live nearby, but culturally, they are stopped from having access with men, like women do that. Because normally they will collect the sample, the doctor or someone trained will collect the sample from the cervix. Now, think of a woman in that trying to meet a man. That is a bit restrictive. So what we did, our first objective was to make sure that let's compare cervix sample collected by a medic and the one collected by an individual, how do they compare? And we found out that we used our people here in the clinic, about 213 of them, collected same day, different samples. The medic will collect one, and then we gave them a poster how to position themselves and collect the sample, and then we tested both of them. So we found out that it was really, really comparable. There were in 213 people that were in that small part of the study, 187 had concordant results, the same result from the medic sample, and the same result from the one they collected themselves. The 26 that were discordant, 18 of them were as a result of being invalid. Now, this test has a good feature. When we do the tests, before we can call a person negative, we detect a human gene. What that tells us is that that sample was well collected before we can say we are negative. If we don't detect that human gene, it means the sample was not well collected, which could have made the person appear to be negative. So in this instance, those that did their self-collection had a lot more invalid because they didn't collect it well. But the good point is that we can identify those ones. And instead of saying a negative, a false negative, we will tell you go and resample that person and test the person again. But the take home from this is that with this, we can now penetrate rural areas. We can now reach those culturally restricted people so that that restriction of not having a female doctor or something to attend to them, they can still be able to take the sample themselves and assess it. We found out that this one they did themselves was 96% accurate. The sensitivity was low, it was at 89, call it 90%. It was ranging from 77 to 96. But the important thing is that whenever we use it, it doesn't give us other false, it's specific, it's 98% specific. So the result was accurate, and we could identify those who were wrongly corrected, and we can restart. That was the first part. And then we went on to look at what's the prevalence and the risk factors. Picking different people. This time around, we work with a lot more people. So in the three geopolitical zones, Lagos, Owerri, and Delta State. And this one was going to occur from May 2020 to December 2021. And we had questionnaires that we give them, asking about different things, your demographics, your attitude, your practice, your social habits, and all of that also had redundant questions that could help us, when people are referring to questions, some people may lie or may not say some things. For instance, someone can say, I'm not socially active, but by the time you check, have you had a several infection, or have you had this or this? So they'll say yes, and then we can infer from both of them and correct a few things. So, and this particular study was recently featured in Frontiers of Oncology, and it was the #1 mentioned in that econ. They compiled a few a series of things on cancer and talked about the future of cancer surveillance. And this study from Nigeria was #1 listed in that compilation. Now, some of the things we found that using 985 people was that they confirmed a few things. Smoking, drinking are very highly associated, in fact, ×2 of the risks associated with being infected. And some of these could be, we are not quite sure, we didn't tell that, but you can postulate. It could be maybe if they drink and they smoke while they are high or intoxicated, they can involve in risky sexual practices, which can predispose them to picking this infection. Like we said, they are prevalent in a lot of places and people can easily pick them. Now, there was an inverse relationship, you noticed, between those who were positive and education status. So what this means is that awareness, this is one of the things we now bring out to the government, awareness programs can help reduce this so that people will know what they are doing. And this awareness can target those HIV positive women who are much prone to it, and then people that smoke. One of the things we find that when women do both smoke and drink, their risk is also ×2, 2.4 times. So it's something to really note. And then those people can be targets of risk reduction program. When we are trying to reduce this thing in the population, we know who to target, because given our numbers in the country, about 200 million, we may not be able to target everybody. But we can target the high risk people and we can actually make an impact. One of the things that that was really, let's say, wasn't very good in the panel was that only 27 people knew that HPV had vaccines, and was only 6% had ever received HPV vaccine. Now, this was done in 2020, 2021. You can imagine, and these vaccines are available and it can prevent these issues. There's a big, in the information center around, you have this big pie chart. It was an information that is sent around to you. You will see that, thankfully, most of the key ones, 16 and 18, they are very little in our population. But we see the other high risk group, there are a lot. But we need to also do something about it. And that's part of where part of our studies come up. We are asking, which vaccines are we using? Some of the vaccines are guaranteed to protect against 2 types of HPV, the 16 and 18. In actual fact, some of them have cross-reactivity. They can also influence and reduce infection from other types of HPV. There are ones they call odd rate. They are like 4, 1, 2, 3, 4. They are guaranteed to protect against 4 types of the HPV. And then the baba of them all is the 9. It can protect against 9 of them, but the cost increases like that. And a bit of concern is that in trying to do this affordably, Nigeria is looking at vaccinating 7.7 young girls. They may not be able to use the 9 one that can protect you against 9 different types. So we also are saying, let these things be available. Some people that can pay for it, they may be able to pay for it and get it themselves. But the great point that our people have started, and we have seen different types. In another presentation, we have seen up to 14 different types that are among the high risks. But these high risks, they may not be the ones leading directly so much as frequently to cancer as the 16 and 18. So one of the things we also did was that in one of the studies, the centers we went to, there were people that come for routine screening. And some of them we recruited to do this study. We asked them, are you willing to share your results? I remember there were 2 different cases I mentioned, 3 different types they use in clinics to check whether people have been infected and changes have occurred in their body. So at the centers where they do this, we went there. So apart from testing them for the HPV, we asked a few of them, can you share with us your results for that visual inspection, knowing whether changes have started happening in your cervix? Some of them shared it. And we saw the similar thing that exists in literature. The 16 and 18 are high among those who are already seeing changes in their cervix. But we also saw a lot of other types. You will see that in some of the papers that we put in that printout they gave to you. So globally, WHO and the whole world is trying to foretell this by using that 90, 70, 90. 90% of young girls vaccinated by age 15, 70% of women screened by 35 years, 90% of women identified as cervical cancer, they should be treated. And over 15 years of monitoring these vaccines, they have been found to be very safe. Over 135 million doses have been given out. And I picked a few information. We don't have that in Nigeria from US. They said among teenage girls, since they started using those vaccines, the infection, and we're not even talking about cancer, infection alone with these strains have dropped by 88%. Among young women, it has dropped by 81%. Among vaccinated women, now the cancers and the pre-cancers dropped by 40%, just because they implemented those cancers. And one of the greatest things they found was that these cancers, they followed something for 12 years. They still found that that cancer, that vaccine they received was still very active and protective even after 12 years. And you know that this vaccine can protect against 90% of the cancers that are caused by HPV. So I've mentioned, I'm trying to wrap up now, that there are different kinds of vaccines, the ones that protect against 2, the ones that protect against 4, and the ones that protect against 9. As much as possible, let them be available. You know, there's a way that people can say, oh, I've taken a vaccine, but they may not know, maybe they took the bivalent, and that in this location, a lot more have a lot more other high risk group, and they can start misbehaving, thinking that they are protected. So those kind of things is the information we want to also put out there, that that people should know which vaccine, because we asked in that clinic where people were taking vaccines, nobody knew the type they are taking. Nobody knew the type they are taking. So it's something they also need to be aware of, to be able to help them to monitor your health. Your health is yours personally. And there was an interesting thing that is helping Nigeria. Earlier, the WHO had asked that women 9 to 14 should be vaccinated 2 doses within 6 months. But they later found out in 2022 that a single dose can also be equally effective. And that's part of what Nigeria is currently using to vaccinate our young girls. So in summary, HPV is common. Almost everybody has had it or will have it at some point in their life. Most infections will clear on its own because your body can fight it and clear. And then it's important to remember that even when you have HPV, even the high risk one, it doesn't mean it will lead to cancer. There are several other things around it. Like I was mentioning in that write-up, there are some things we're also looking at. They are looking now at in WHO and USCDC. They are thinking of why a woman or maybe 2 people will have different stages. I don't want to use the technical name. Okay, there's a stage they call like CNS 1, 2, or 3, and then one goes to cancer, one does not go to cancer. They are looking at other human aspects of the body. There are something they call DNA repair genes that repair damage to DNA. When people have a good one, they are easy to repair the damage. And then when people don't have a very good one, the damage can stay long and accumulate and can lead to some of these things. So they are looking at this. What can you do to reduce your risk? Get vaccinated, particularly if you are not sexually exposed and under 25. Get screened and tested regularly. Practice safe sex. Protect your partner, stick to one person. All of these will help. And then vaccination that we are doing in Nigeria, let's encourage our siblings, our young ones to be vaccinated. I remember having to write to my daughter's school, giving them permission. My daughter should be vaccinated. And all of these are different ways to stop it. And then remember the key risk factors: smoking and drinking. You should try and reduce those things.
As already introduced, my name is Dr. Inalda. My focus is infectious diseases epidemiology and genetic basis of antimicrobial resistance, focusing on antimicrobial resistance surveillance and antimicrobial stewardship. First, I would like to maybe explain what antimicrobial resistance is. It's the situation whereby microorganisms evolve or mutate in such a manner that the drugs that are or medicines that are originally targeted to kill them, they find a way to resist or boycott them in a manner that they are no longer able to kill them. So we say that those organisms have become resistant to this particular medicine, which initially is targeted to kill them. So we are now noticing recently that there is increase or rise in antimicrobial resistance. In fact, currently, it's one of the major pressing global health threats. And it is even threatening to overturn the gains that has been made over the years with the use of antibiotics for treatment of numerous infectious diseases that we have. Following the discovery of antibiotics in the 1920s, now, antibiotics was like the best thing that has ever happened to us. We are using it to treat infectious diseases, but recently and currently we are having high levels of resistance, such that these organisms are no longer responding to these medicines that are supposed to kill them. So this is a major threat, especially in this 21st century. And it is even limiting us from attaining the Sustainable Development Goal plan of good health and well-being for all. So my team and I have focused our interest in looking at ways to mitigate the emergence and spread of this resistance. And our interest is rooted on the One Health phenomenon. One Health paradigm recognizes that there is interconnectedness between the humans, animals, and the ecosystem. So these humans, animals, and the environment interact in such a manner that there is transmission of infection across these different sectors. So we have tried to look at avenues to make sure that this transmission does not occur. So one of our major contributions was looking at strengthening AMR surveillance using sentinel sites in Lagos State. So we structured a survey using 4 healthcare facilities as our sentinel site to look at what are the clinical pattern of AMR amongst people that are already sick in the hospital with different infections. So we surveyed these sentinel sites, and one of the major things that came out there, we noticed the results reported high level of resistance to 3rd generation cephalosporins. These cephalosporins are beta-lactam drugs. They are broad-spectrum beta-lactam drugs used to treat severe infection, because we have the 1st generation and we have the 2nd generation. So 3rd generation is basically reserved for infections that have refused to yield to the 1st and 2nd generation. But we are now seeing that even these 3rd generation antibiotics that are our reserve antibiotics are now, the organisms are now developing resistance, and we saw it in the clinical cases in Lagos State across the 4 sentinel sites that we surveyed. And this was an alarming issue for us. So we noted this, and then we also reported about that. So one of the major outputs of this particular survey was that we were able to inform the facilities to have facility-specific antibiograms that they can develop for their own facility, which enables them or facilitates and helps them in empirical treatment, which we know 80% of prescriptions are empirical. But if they can be guided by an antibiogram that is facility-specific, it can also help them. So what else we also found was that we identified the predictors and risk factors that are responsible for this level of resistance we are seeing. What are the precipitating factors? What are the people doing differently that is causing them to be liable to these infections that are resistant? We also tried to get information about that. We noticed that it's because of human behavior, basically. Misuse and abuse of these antibiotics is a major factor that fuels resistance, that fuels transmission. So irrespective of whether you are using it correctly or not, if your neighbor is not using it correctly, he can transmit a resistant infection to you, and you can come down with a resistant disease. So we also provided a baseline data that could guide national effort. We know there is already a national effort to tackle AMR. So we're able to also contribute to that effort by providing some baseline data for that. So secondly, another major contribution we had was in the area of environmental and wastewater surveillance as an early warning system to target both pandemic and epidemic prone pathogens. So what we did was to develop a structural survey of wastewater canals in Lagos State, using it as, evaluating it as an early warning tool that can signal us an impending outbreak, whether it's epidemic or pandemic outbreak. So we looked for pathogens of public health importance, including COVID-19 at that time, because it was a major issue. So at the end of the study, we're also using that wastewater tracking to look at antimicrobial resistant transmission. The bacteria that are resistant in the wastewater, they are resistant genes, because it's those genes that help them facilitate resistance. So we look for the genes. So at the end of that study, one major output of that study was that we were able to find that there were several pathogens of public health importance, especially the bacterial pathogens. Then it also signaled that COVID-19 the transmission was kind of going down, which correlated with the current, the then report by NCDC that the transmission was going down. So we were also able to demonstrate it from the wastewater that the transmission level was going down. And then we identified cholera, notably cholera, Vibrio cholerae 01, which was responsible for cholera outbreak. As we all know, there is always yearly annual cholera outbreak, especially in Lagos State. So when we surveyed this wastewater canal, and just to point out, it was done in all the 20 local governments in Lagos State, we were able to identify that out of the 20 local governments, 9 of them had Vibrio cholera. were being incubated in their wastewater canals. And this was very alarming because it's not just Vibrio cholerae, but the old one that is responsible for cholera outbreak. So this warranted us writing a policy advisory to Lagos State then, warning them of an impending outbreak of cholera that was going to come. And just like we warned, the cholera actually came in 2024, and it was a massive one. In fact, it came out in 36 out of 37 states in Nigeria, and we had massive morbidity and mortality due to this outbreak. So what this whole study was able to confirm to us that wastewater-based epidemiology or monitoring is a good, cost-effective tool that can be used for monitoring outbreak of both pandemic and epidemic-prone pathogens. And we were able to demonstrate that very well. And then also look at pandemic preparedness. It's an opportunity for us to tap into this and leverage it for pandemic preparedness, because we don't know what the future pandemic, the upcoming one, will be. So we were able to demonstrate this, and then we provided evidence-based recommendation for public health authorities to use to formulate policies. So the environmental surveillance research represents a forward-looking strategy for epidemic intelligence in rapidly urbanizing cities like Lagos State. So that was that. And we also, in the process of doing this surveillance, we also did an epidemiological survey of the people to know what their risk behaviors are for those organisms that we're seeing in their wastewater. We found out that people defecated directly in the wastewater. They put their hard waste there, and it blocks the canal. So what happens is that during the rainy season, these canals are clogged, they overflow, and then trickle back into their homes, and then infect them, contaminate their food, their utensils, and all that. So this was a major risk behavior. So that warranted a behavior change intervention to ensure that people know the right way to handle. So finally, we also found out that you cannot do surveillance in isolation. It is very important that you look at what are the risky behaviors that are precipitating this surveillance. So to do that, we also champion interventions like workshops and trainings, trying to train prescribers. First, we started from baseline data on knowledge, attitude, and practice. What are the practices by the general public, by the prescribers themselves, which are the medical doctors, pharmacists? What are their practices that are really fueling this resistance? So we identified gaps, because even the prescribers are they are under pressure to prescribe. That is one of the reasons why they prescribe this thing. And then the general public are saying, we really don't know much, so we just take them because we think they are very helpful. So we found out all these risky behaviors and then we designed evidence-based intervention to tackle this through workshops and trainings, and also creating awareness campaign to the general public, telling them that you need to change your attitude or outlook, because your behavior or actions and inactions are indirectly or directly also precipitating the emergence of antimicrobial resistance. And I think I will stop here. Thank you.
At the end of today, 22 Nigerian women have died from cervical cancer, and 33 other women have gotten infection. The second also wants us to go away from here is to also go away from here is to know that why is this happening? One, because of the poor knowledge, people are not aware. People are not being vaccinated, and people present late. Even when the conditions, they notice some sign, like after having sexual intercourse and there's bleeding. And the person is supposed to report to the hospital. Because of the area involved, the woman keeps it to herself. So by the time people, and because most times cancers don't cause pain early, the signs are there, they don't report. And by the time they're reporting, usually late stage, 3 and 4, when nothing happens. Luckily for us, the government have introduced the vaccination. Because the two major areas how we can prevent cervical cancer is through primary prevention, which is vaccinating our young girls and also boys. But because of the limitation in funding, the government started with the primary, the person that who would die for the girls. By the time the government have made sure that all the girls are vaccinated, the government will now maybe move to the boys. In other countries, they are now vaccinating both girls and boys. But for now, we want to focus the limited resources on people who. The second one, for those people who are already past the age of vaccination and sexually active, to screen for cervical cancer. Presently now, our screening is not well organized, but Chika have said something. One of the challenges people are not coming for screening because of the issue of if a woman is having some symptoms, some signs in the private area, genital area, she's likely to present to a doctor. But the woman who has no signs is very unlikely to come to hospital for to put her legs or something. But now, with work done for other places and the NIMR, we'll be able to show that when the self-sample collection is as good as the one collected by the doctor, if you use the high performance human papillomavirus screening. And the next one I want to say is that when you do a population-based study, 16, 18, and 45 that we identified are those ones at highest risk of changing to causing the cervical cancer infection, because what actually causes most women who have that virus in their life. But what actually causes cervical cancer is the persistence of that virus. And evidence have shown that when 16 and 18, when they occur, they tend to persist more than the other. But what normally happens in the general population, when people do study the general population, 16 and 18 seems to be low. But however, when they occur, in a systematic review we did by the team from NIMR, the prevalence of high-risk cervical cancer is 25%. Systematic review means, apart from the study, primary study we've done, every other study done about human papillomavirus in Nigeria, work with at 25%. That's the prevalence of high-risk human papillomavirus. 16 and 9%, 18 and 20%. So when they occur, they tend to persist more than the other people.
Sir, let me start with Prof. Prof, I want to know how NIMR is translating these research findings into policy and action, from what we have been listening to the different departments and all that. Can you tell us how NIMR is translating these research findings into policy and action?
That's the DG, right?
The DG, yeah.
No, let me come in there to the self-sample screening, Chika described, is already in the current cervical cancer guideline and plan. I've already integrated into. We are working with National Cancer Control Program in the program. NIMR nominates people who are members of that committee. And I'm a member of that cervical cancer technical working group. So we represent NIMR in those committees. And as we are doing this work, we are passing it to those various ministry, organs in the ministry that translate it to policy. Chairman, I answer the question.
Yes, so let me also add for AMR too. We are also part of the National Technical Working Group, which is anchored by NCDC on AMR. So we are involved in developing policies in NIMR, and everything we do also fits into their efforts. We provide data that helps them to facilitate policy making as well.
So can we now say that most of the findings are being used by the Federal Ministry of Health or the federal government, federal government?
Yes, any work done here that is properly, remember, that is properly done, and you pass it through that, is what they call technical working group. It's not every information you give them that translates into policy. That committee have to look at it based on resources availability, the evidence of evidence you provide before you can translate to, because at that committee, a lot of jargons come into that committee, but they have to be seen before it becomes into
Chairman, maybe let me just talk to you, because I know you are going for an editorial meeting. Maybe if we begin to see some of these stories on our front pages, people in government, they will know NIMR is doing. Thank you.
For example, Chuma, what you say before you go, if you say there's a media chat in NIMR today, and NIMR can report that 22 million died today. Died today. You know, it rings a bell. That one will come. That's what we're trying to say.
But it's true, but
No,
sensational.
but that's the truth. That's the truth. Then you bring it. No, you bring it that. But you still need to do more work. Like Chika said, he identified a gap. That's where NIMR needs support. We need to identify what makes that this person has HPV 16, 18 infection. It doesn't progress to disease. But the other person has the same infection or progresses to disease, apart from HIV. What are other things? NIMR needs funding to be able to find that. Yes.
So there's a pledge from Chairman that we will begin to see our stories from
The only thing I just want to caution about is that when we start talking about cancer, we need to be aware of the multifactorial nature of it.
Yeah.
It's not a question of one single entity.
okay, but looking at your study, you talk about 34% HPV infection, and when you now look at you compare to the previous national data, will you not say that there's a kind of rising trend?
So that was 34 we got in the 2015 study. In the 2022 study we got 25%. And then the other one, I think the one we had got about 19 or something. It just depends on who's handled. In some of them we focus on high risk group, like female sex workers. It will not be the same. So if in one of the papers you will see it, we put it by the groups. General population, it was low. Female sex workers, pregnant women have gone through something before they became pregnant. They were at the highest, followed by female sex workers. But general population was low. So it depends on who is among the people you sample. And that's what we had. But by the time you generalize the figure and do an average, you get an idea of what is going on.
In HIV positive, it's about 61%. People who are immunocompromised, the prevalence goes about 71%. So, it's not like he said, cause of cancer is multifactorial. It's only several cancers identified and not cause of the body. Like I said, two people can have infection, but one person will progress, but one person will regress. So what are those things that make the person progress? Those are where there's the gaps.
Thank you.
I want to
the question has to do with that. You talked about 36 states. I mean, talking to Ghana, there was this outbreak talked about that we did it 20 local governments in the states, and you now talked about having a particular in some states and remaining only one state that was not. So what made that state different from other states where you had the outbreak? Why was that state a standalone? What was the specific thing? What made it special that it wasn't part of other states that had the outbreak?
Okay, thank you for that. So let me borrow the cost may be multifactorial because it's possible that that state may not have been testing for cholera. Because you notice what happened with COVID, Lagos was only stopping the chart, but that was because more testing was being done in Lagos State. So this was according to the report by NCDC. They were taking statistics across it. And Lagos was actually topping the chart in that 2024 outbreak of cholera. It was almost in all the local governments in Lagos State during that 24 outbreak. But some states reported, some minimally, some may not have. So we can't really say it was because there was no outbreak. It may just be because it was not being diagnosed or reported or detected. But that was the statistics for that year.
Okay, my question is around the HPV and cervical cancer. You know, we've been talking about the vaccine for teens. Then I want to know about the screening for people who have, reached have passed the threshold with the age gap that you had mentioned. Because last year, in 2024, I was doing a story on HPV and cervical cancer, and I found out that we don't have screening centers. So I don't know if NIMR is a screening center. We don't have screening centers that are free, because that would encourage people to come out. If you're telling somebody that you need to go and screen for such a thing, and then they will go to a hospital. Like I went to Lutz, pap smear at Lutz is around 8,500 or so. If you go to private clinics, like I went to Mikio. Mikio told me 17,000 or something. And then even the other more advanced screening at Lutz, I think is 30,000 or so. Mikio.
Yeah,
So the other
thank
one,
you so much. I've had it. We'll see come back to the same thing we keep talking about. And I keep saying it. As you call it, it's not my portion center. I can see your glasses you're wearing. That glass will not be less than 50,000. I can see your lipstick. I can see your wristwatch. But you are saying a test that is 5,000 is expensive. How much is an HPV? No, there's none that will be less than 5,000. No, I'm just saying there's none that will be less than 5,000. What I tell people is that we owe it to ourselves to do what is right. When I talk to parents, when I go to school and talk to parents about vaccinating their daughter, I said, you are saving money to build houses that are going to bequeath to your children. It's the only person who is alive. The same father who is saving money to buy stuff for the children, saving money to buy houses for the child, is waiting for government to provide free vaccination for the girl. I'm not saying we should not hold government accountable for what they're supposed to do. But will you watch your daughter not receive what they're supposed to get because you're waiting for somebody else to do that? I think what we need to do, one of the things I've learned over time, mothers are ready to do anything to save their children. It's because we've not passed it to them to let them know that if you vaccinate your daughter, you've saved them from having cervical cancer. I think that's where we are missing. That's where what is missing. Translating the knowledge of what we do to mothers. Look at prevention of mother to child transmission of HIV. Mothers are ready to do everything, make sure that their children come out negative. The same thing, if instead of we journalists talking about the cost of vaccination and focus on the way of vaccinating that child. One dose prevents that girl from having cervical cancer for life. I think if that's the gift the mother can give to that child, or the parent can give to that child, I think that's not too much. The same thing for secondary prevention, which is screening. I don't think if you do the HPV testing, high performance test, and it comes out negative, what you needed to do another test 10 years later, 5 to 10 years later, and you do that second one, if it's negative, you are covered for life. Imagine spending, how we say in Luke, it says how much? 30 times to 60,000 for a life to protect yourself. If you do it at that stage and we identify that you have those HPV, we'll do what we call colposcopy and take sample for histology or histology and follow the person. So they can prevent it at that early stage. So I think when it comes to health, you cannot measure health. You cannot quantify health by NIMR or no matter how much, we always ascribe everybody, if I say everybody should bring out phone, there's nobody who's using a phone that there's no 100,000 or 50,000. But it can be stolen on the next bus stop. And if it's stolen, the next day, we'll replace it. Why are we always talking about NIMR when it comes to health? Journalists, I think we owe it to the country for people start quantifying health by money rather than let me coming back to NIMR. NIMR is the research institute. We are not a service organization, except we have a funding to do a research. During that period, we are doing that research. People were recruited during that period, get it free of charge. There's current one we are doing screening for HIV positive, and it's free of charge. When we did the study, Chika reported, it was free of charge, nobody was charged anything. So, NIMR is not fully funded, it's not funded for services. We can only have those services when we have a funding to provide those services. So, people who are in that research data gets them free of charge. So I just wanted to mention it. So maybe we think about it.
I will be very cautious. NIMR is purely a research center.
Yes.
The joke of routine screening, whatever, be restricted to hospitals, general hospitals, primary healthcare centers, teaching hospitals where necessary. NIMR cannot add that because we don't have that kind of facility. We don't have. NIMR is not equipped for that. It's not part of NIMR's mandate. And like you rightly said, 8,000 naira per person, 15,000. It's no money.
When you have when people who have cervical cancer tell you what they go through in the treatment,
It's a different thing if we have full health insurance coverage, and such things can be covered.
So, Barrister, when you were speaking, you mentioned some of the causes of smoking, but when you were talking, you mentioned some symptoms, and one symptom was bleeding. Are there any other symptoms?
Sorry. Not causes.
yes,
Associated.
Okay. Things that are associated.
Yes.
I think that was explained again. When you are drinking, you are loose, you are on drugs, you are loose. I believe we've had a very interesting session, and I want to see this opportunity to say a big thank you to us for finding time to come. listen to our researchers, clear a few points that have been agitating our minds before now. I'm looking forward to the next episode. I'm sure it will be equally enjoyable. And I want to say a big thank you to my colleagues, Dr. Omala, for their presentation. I'm sure we can talk to them further if find it necessary. I'm glad that Professor Ezechi is here to shed some light on certain clinical aspects. And that's very important. When we're putting the message across to the general population, we want to say these things in the clinical context. We only hope that the people out there will listen to us. We only hope that the government will listen to us. And when it comes to the need for funding, NIMR will be